Good afternoon or morning. My name is Scott Kelly. I'm Vice President of Sanford Guide. We are pleased to have you here with us for our kickoff event for our open house, which is the COVID-19 panel discussion with 3 of the Sanford Guide editors. Starting with Dr. Helen Boucher. Helen is Chief of the Division of Geographic Medicine and Infectious Disease and Director at the Tufts Center for Integrated Management for Antimicrobial Resistance. She's Director of Tufts Medical Center's Heart, Transplant, and Ventricular Assisted Device Infectious Disease Program, Professor of Medicine at Tufts University School of Medicine. Our next panelist is Kami Kim MD, Professor of Internal Medicine and Director of the Division of Infectious Diseases and Internal Medicine at Morsani College of Medicine in the University of South Florida, Tampa. Her laboratory work focuses on the pathogenesis of toxoplasmosis and malaria. She's a graduate of Harvard University and Columbia College of Physicians and Surgeons. And finally, I'd like to welcome our third panelist, Michael Saag MD, who's the Associate Dean for Global Medicine, Professor of Medicine, and Director of the Center for AIDS Research at the University of Alabama, Birmingham. Dr. Saag is an internationally recognized AIDS expert and served as HIV Medicine Association member of the IDSA Board of Directors. So welcome to our 3 panelists, and I will turn the conversation over to you.
Great. Thank you, Scott. We decided that we would just make this an open forum, knowing that most of you already have a pretty good understanding of COVID. You're probably taking care of dozens, if not hundreds of patients with it. So rather than going through a slideshow and the basics, we thought we'd be more efficient just having a conversation. So maybe we'll start off with each of us just mentioning 2 minutes about what our involvement personally with COVID has been. And maybe Kami, I'll start with you.
So thanks, Mike. So I am obviously a board certified infectious disease physician, and most of my career has actually been based in basic science research in molecular parasitology. But I also grew up in the HIV era and have been colleagues and friends with many HIV researchers. And I also recently developed a translational research program in malaria in Malawi. And it's very interesting. I hadn't done a lot of clinical research before this happened, but all of my training, it seems like it prepared me for COVID in that I was on my way from Malawi when we got our first case here, and I flew back here, and I basically lived in our hospital helping, organize the clinical services, helping the lab as far as figuring out testing, working to set out a basic science laboratory where we have BSL-2, BSL-3 capacities. And so I've actually lived the life of a true physician scientist where I've done actually everything from bench to bedside. And, it's been a very rewarding experience.
Great. Helen.
Great. Hi, everybody. So here at Tufts, I lead our division of infectious diseases, and we've been very busy since the beginning of the epidemic, and certainly focused our efforts here on managing the surge that we had in April. That was huge here in Boston. And I also lead the effort across our healthcare system. So we have 3 outside hospitals in the community, and we have a sort of well-integrated infectious disease team. And so we work together on things like access to clinical trials. We ran a number of clinical trials during the surge, including remdesivir, convalescent plasma, cerulumab. We have a nitric oxide study, and now we have kind of the next wave of trials that we're standing up, including some outpatient trials should we have another surge this fall. So that's been very, rewarding, challenging. And then the latest thing that we're involved in is testing of students. So we're testing college students on the order of 1,500 people a day from the Tufts University Boston campus and Emerson College right down the street here in Boston. So that's been another whole kind of experience to learn about, and happy to talk about any of that. And then just to bring it full circle, we're also working with the public school system on the K through 12, getting those kids back to school. And we're doing a pilot testing program in the 5 towns in the K through 12. So that's another sort of interesting aspect of this. I don't know if people are interested in talking about, but that's a little highlight. Back to you, Mike.
Thanks, Helen. So I've been, first off, I started off with the infection, so I've got that perspective. Back in March, I picked up COVID and was sick for about 14 days, never had to get hospitalized, but was pretty sick at home for 8 of the 14 days. I describe it kind of as a Groundhog Day experience where the mornings would be fine and I thought it was gone. And then by about 5 or 7 in the evening, I start getting chills, fever, what I called fuzzy thinking, at least more fuzzy than normal, headache, fatigue, couldn't sleep, and having some respiratory difficulty, but never having a pulse ox drop below 90. And I was watching it like every 5 minutes. The horror of it really was the notion that what was coming next. At 2 in the morning, pulse ox would drop to 91, maybe 90, and I go, I don't want to go to the hospital. And then it sort of settled in, and the next morning was better. That happened for 8 days in a row. Pretty horrible experience, but it does help me relate. The other thing that I've been up to is, just like Helen, I led a testing initiative for all the campuses, college universities in the state of Alabama. And we tested back to school re-entry testing, set that up in like 6 weeks. And it was about 12,000 tests a day for an intense period of time. The overall prevalence rate of students coming back was 0.75%. And yet, within about 3 to 5 days of a couple of the campuses getting back, most notably University of Alabama and Auburn, they had a huge outbreak at each of these campuses, and then we got involved in that. So now we're in charge, and it's gotten better. The students are now participating, everyone's gotten everybody's attention, and they're doing well. And we're now involved in Sentinel testing on all these campuses, both faculty, students, and staff. So that's a large ordeal, but we're not doing K through 12. So maybe I'll kick off the question back to you, Helen. And one of my concerns is that K through 12 could be the source of what I would call an October surprise, that for us, a lot of the kids are back in school from elementary to high school, and there's no testing going on. And just using our college campuses as an example, I'm very concerned that kids are transmitting, bringing it home. Mom and dad will get sick in about 2 weeks, and we'll have another spike or surge or whatever you want to call it. What are your thoughts? Sorry, you're muted. Yeah. Still can't hear. Okay. So there we go. Now you're back.
Okay. So, the first thing is in Massachusetts, our rates are very, very low right now. So it's important. The most fundamental thing, right, is what's going on around you. So our state numbers are extremely low, like 1%. We've been below 1% since I think middle of August. So really good. There are still some hotspot towns, but by and large, the state is good. The most important testing for the K through 12 is the ability to test symptomatic kids quickly. And in our healthcare system, that's not always so easy. So that was the first thing we addressed, was making sure there was a way to test symptomatic kids and faculty quickly and staff of the schools. Then in a pilot way with the Broad Institute here in Boston, we set up this pilot to test students before they go back. They're going back in what they call a hybrid next week. So 2 days a week, and then the rest on Zoom to get a baseline. And then the hope is that they'll do a little bit of Sentinel testing after that to see. I think it's going to address a lot of the fear. There's still a lot of fear among the faculty about coming back to school and the families of the students. And I think we'll learn, Mike, to your point, about what it adds, if anything, to all the other measures that are being taken.
What's Massachusetts or Boston's relative infection rate right now? You may have said that, I missed it.
The RT, it's like 1.12, I think, yesterday. So it's a little higher than it was a few weeks ago, but the percent positivity rate is lower.
But it's 1.1 per 100,000 or so, is that?
Oh no, the incidence is about 5 per 100,000.
Okay, so where we are, we're about 20 per 100,000, and a couple of weeks ago we were as high as like 33, and so we're nowhere near. We're an order of magnitude off. Kami, what are you seeing in Tampa?
So our figures aren't quite as high as yours, but I don't know rate of per 100,000, but we were up into the teens. Our rate of positivity is probably around maybe 5%. We've had a couple worrisome issues in that, in the beginning of June, so we were very lucky. We didn't have the wave that they had in the Northeast. And our healthcare system, was very proactive. So we had on-site testing so we could see what was going on. And we actually offered testing very early to our healthcare workers and giving them liberal testing for any kind of, exposure or not. Our test rate was still only 2% among healthcare workers. And in the community, it was probably below 1%. And then we had a blip in July. And so the healthcare worker percentage went up to about 7%. And then it's gone down. But recently, what's concerning is that we've started to have a few more healthcare workers, like we used to have 3 or 4 a day, and now we have 5 a day. Is that statistically significant? Maybe not, but that's what happened in June. And then what we're happening is the overall positivity hasn't gone up that much, but there seem to be more tests out there, and the median age is going down. Right. So those are things that we are observing in early June that make me concerned that we may be on the cusp of another surge.
Yeah, it's hard to know. And the hard part is that for us, we have the least business, in my opinion, going back to full bore K through 12, yet that's what we're doing in a lot of school systems. Because in addition to the rate I gave you, our test positivity is just about 16%.
Wow.
And you kind of go, huh? And it's been as high as 22% just 2 weeks ago when they made decisions. So we don't have a whole lot of control over what's going on. It's a big concern. But in our case, healthcare workers, I'm pretty confident, are becoming infected outside of the hospital setting and not so much in. Is that your thought as well?
Well, we've done very good studies because our employee health people collect a lot of data. And like I said, they were very proactive as we got online testing, testing in-house, with less than 24-hour turnaround mid-March. And then we opened up testing to basically any staff and faculty who wanted to test. So we have a pretty good idea of what's going on. And then we collected the epidemiology, and basically everything tracks to community prevalence and community habits. They also did some contact evaluations, and 85%, it was clearly community acquired, usually household. And among the people who got in the hospital, it was almost always people who let their guard down and took breaks together in the break room. And so I would say
that's what they call it.
5 or 6% of people actually had an outbreak that had a case that may have been hospital acquired that could be nosocomial. So our conclusion is PPE probably works. I also forgot to say, among the kids, I haven't looked at the most recent data, but among the kids, even though our overall rate was below 10% among all comers and adults, the rate of positivity in children was above 10% last week. I don't know what it is this week, but so there are some worrisome indications that kids could be a problem.
Helen, any concerns about outbreaks among healthcare workers?
Well, I would say that we definitely we have evidence that what we've seen in healthcare workers reflects the community. And if you go back and look to when we went to universal mask and had lockdown, the employee numbers went straight down. And we've, knock on wood, been very, very flat. But to echo Kami's point, there was a little cluster reported at one of the hospitals out in Springfield, Mass, related to a break room. And so we've been doing a lot of work, and we're experiencing what I kind of call pandemic fatigue. I think people are tired of it. They don't want to think about it. So we're working really hard on reminding everybody about the numbers of individuals who should be in rooms. It's the rounding room, it's the break room, it's wearing the mask and eye protection all the time, and really trying to kind of get people to start thinking about it again.
Yeah, those are great points. And it's not just hospitals and hospital workers or clinics, it's the entire communities just over this in a lot of cases. And even look what's happening in Europe now, and Israel for that matter, where they had it under control and now it's starting to break. People just get tired. And New York, I know for a fact, has stayed really under control, but they're not opening up restaurants yet, and nor are they opening up bars, outdoor dining. And that's what it unfortunately takes, it seems like.
I know. Well, and I'm worried because today it was like 43 degrees when I drove to work this morning. So the weather's already starting to change.
Right.
So we're not going to be outdoor dining for long.
Yeah, well, well, that gets to the point then about some of the questions that we've received. So let's get to those. So infectivity, maybe the co-infection with flu and COVID could be a double sort of a twofer. If people wore masks, wouldn't both go down, right?
Yes.
But we hope so. And there was an MMWR, I think the week before last, looking at the Southern Hemisphere, and it was very reassuring, right? The data were very reassuring that there was very little influenza. So
Yeah.
that's the good news. But I think the thing for us to emphasize is the importance of getting the flu vaccine.
Absolutely.
Whether or not you're in healthcare, I think this year it's more important than ever.
We need both. So here's another question. What about the current tests for infectivity? Is there any way to test someone? Does a nasal swab help? What are your thoughts on that?
So all the studies, all right, it's very controversial. And I think the gold standard for infectivity is not one that you can actually really use, which is culture, like basically taking the isolate from water sample and use it in cultures. That has to be done in a BSL-3 facility. Not all labs have access to that. And I think it's also pretty clear that you have to have a pretty high inoculum in whatever biological sample you did to inoculate. So I think it's pretty controversial as far as how you correlate that. The studies that have been published, and I think not enough has been done, seem to suggest that your infectivity as far as culture correlates with the number of particles that you can detect in, by PCR. So there may, and that wouldn't be surprising. Pretty much all infectious diseases, I mean, obviously HIV is a great example, your chance of giving it to somebody else is better if you have a higher viral load. So I think that seems to be coming out. The question is whether there is a direct correlation, and also, there's other fancier approaches looking at subgenomic PCRs, but I don't know that anyone really knows how to measure it.
All right, so that's the point maybe. Let's get real. We're not going to be able to get the number of cycles that it took to get a positive test from the lab. So Helen, what do you say to people about somebody, we'll go through two scenarios. One, the person actually had, let's say they're asymptomatic, they had a positive test. Let's start with that one. I'll come back with a second. So what are your thoughts about that? What do you tell that person?
So an asymptomatic individual with a positive test.
Yeah.
I tell that person to isolate for at least 10 days. And, if they're lucky, it's asymptomatic disease. And after 10 days, they can come out of isolation, but they might be unlucky and they might actually be pre-symptomatic, right? They might not yet be ill. So it's very, very important that they isolate and that we do contact tracing for those individuals.
So 10 days after the positive test, and then we use the term isolation, right? And then for their contacts, what do you do for them?
So for the contacts, this is really important, right? So for the contacts, the recommendation is that they are tested and quarantined. And yes, that means the recommendation is that they're tested early to make sure they're not already infected and that we don't need to do contact tracing around them. And then they're quarantined. And during the period of quarantine, if they develop symptoms, then they would be tested again.
Yeah. So and that's for 14 days, right?
Correct.
You go for 10 days.
14. In our state, it's 14.
Fair, right? The sort of poor person who just happened to be a contact is in quarantine longer than the positive person's in isolation.
Well,
So
we had that. We've that with the college students, this has come up, and there's a little dialogue. I think it's on EIN or one of the listservs about some data from the CDC suggesting that you might even be able to get people out of isolation even sooner than 10 days, which is controversial. But that's a real thing, that disparity.
And that required 2 positive tests, if I remember correctly. If somebody's in isolation, they tested positive, they were asymptomatic. A week later, you do 24 hours apart, 2 tests, you might get them out in 8 days or something is what they're talking about. Yeah. Tommy, what do you think about in those scenarios, besides the getting out of isolation, but retesting say 14 days after a positive test or 21 days. Does that tell you anything? Do you recommend that?
We generally do not, but there is a lot of confusion and controversy.
Let's clear up the confusion.
Yeah. So so one thing that's very clear is that people's tests can be positive many, many weeks after they clinically have completely recovered. And the current thinking based on the basic science studies as far as infectivity using gold standard assays is very, very, very few people, probably more than 90%, have anything that resembles infectious virus after about 8 or 9 days.
Right.
So based on that, that's why people are usually allowed to come out of, infection prevention precautions and things like that after 10 days. And I think one thing that people also get confused about is there's when they're infective, but part of the 14 days for people who are exposed is the incubation period is not the same period as when they're infective. So they can come up with clinically apparent disease as long as 14 days after being exposed. But then once they come down with symptoms, they're not unlikely to be infectious past 10 days. So because of the fact that we know the vast majority of people will not be infectious, but may well have a positive test, we don't recommend testing. It's very difficult in certain cases, like people who are severely immunocompromised or may have to go back to a nursing facility or someplace where they're, because of the abundance of caution or because someone may be relatively immunosuppressed of taking someone back, then sometimes for pragmatic reasons we retest. But in general, we've been using the not that sick, 10 days, get them out and not retesting. And then for people who might have more chronic illness and may be less able to fight off the infection, then we would go for the 21 days. Yeah. And we sometimes, when we're not sure, do check antibodies, because if you have the development of antibodies, the suggestion is from the basic science studies is that's when you're probably starting to clear virus and less infectious, but that's controversial.
Yeah. So for the purposes of our messaging, I think is that in general, do not retest unless you're going for that early isolation release. And I think even that's debatable. So because those tests can be positive for weeks, if not a month or two afterwards. And we'll talk about that in a second. If we're going to probably have to tighten up here because we got a number of questions to get to. So we'll keep our answers to a little bit shorter, but let's go to the types of tests. So Helen, what do you think are the best tests? And I'm going to say just in terms of diagnostics of an actual acute infection.
Right. So for acute infection today, it's PCR testing, right? And some of the platforms vary in their sensitivity. And so you need to be familiar with the sensitivity of the platform that you're using. In general, the tests that take longer are more sensitive, and the rapid tests are less sensitive. They're still very useful. And coming back to your earlier comment about infectivity, Mike, the Abbott ID now and the Cepheid and those tests that are done within an hour, they detect virus that's, in a way that is reliable and reassuring. A negative in that test is very reassuring that the individual is not infectious. The other thing to talk about that you may want to talk about is pooling, because a lot of us are doing pooling, and that saves money in reagents and maybe affects sensitivity a little bit, but with a really sensitive machine like the Panther, you can still rely on those results that a negative is a negative, and it's been very effective for some of us.
So let's dig into that. So I'm going to divide up the comments. That was firstly just somebody who's symptomatic or somebody who needs contact tracing. Then the PCR is the most sensitive, but the antigen tests are pretty good, especially for symptomatics. Yes. And a positive test is almost certainly a true positive. Yes. A negative test, what about that? In the setting of somebody with classic COVID symptoms and you really think they've got it, you even do a PCR, it can be negative, right? And they still have COVID.
Right.
So there's
So
two
that's where-
questions.
yeah, go ahead, Kim.
Sorry. I think there's two questions. Number one, are they infectious? And I think a test being negative probably is pretty suggestive that they're not very infectious. But then there's also people who have clinical disease, because we know that COVID has two phases, the sort of virus phase and the inflammatory phase. And so we may have people who are, say, positive on a sputum sample and truly have COVID infection. And if their respiratory function gets bad enough that they would be, say, intubated, that would be potentially a serious infection control issue for the staff taking care of them. So this is why they could have a negative nasopharyngeal, a positive sputum, and then be infectious. So that's important. But then they also could be negative completely in the PCR, but still have COVID because of the inflammatory consequences. So I think there's two issues: trying to determine who's infectious, and then also whether they actually have the disease and how you would treat them based on establishing the diagnosis.
Right. But as a rule of thumb, we're not going to be using the testing too much for determining infectivity, because we're going to use the other rules. In general, I mean, your interpretation is correct, but we're not going to make that recommendation, I don't think. But as far as best specimen, a BAL is probably the best. Sputum from a really good deep collection is good, and then nasopharyngeal, pharyngeal. So Helen, let me segue back to Sentinel testing, which your group, our group, has been doing. Kami, I don't remember if you guys are doing that in Tampa, but we are, like you, doing this pooled testing, and we're doing up to 8 per pool, sometimes 4, depending on the prevalence. And the 8 maybe takes a little bit of hit on sensitivity, but not much if it's a nasal swab. So what are you guys doing up in Boston, Helen?
So we're at our hospital, we're doing pools of 5, and we're only doing in the patients who are kind of surveillance testing, not symptomatic individuals.
Correct.
We've had very good success with that. The students are being done at the Broad, who uses robotics, so they're not using pooling in that setting.
Okay, all right. So that works. What about spit versus nasal swab?
Really good question, right? So the folks at UMass, they validated saliva, but found that it was very labor intensive to collect. We have not attempted to validate saliva. We've just gone to anterior nares at our place.
Yeah.
So we, for inpatients, didn't have a very good experience with saliva, so we abandoned it. So we tried saliva, nasal, and I think it's probably because a lot of these inpatients are very, very sick and very dehydrated, because we try to minimize their fluids and things like that. But we're actually doing pooled testing at the university and getting saliva specimens, sort of doing random sampling, and then all pooled. So in pools of either 4 or 5, some random testing, and also some screening of athletes and things like that. And that has all been saliva samples. And so far, that's actually worked out very well. Yeah. And they've been confirming the saliva tests, when the pool is positive. They've actually been doing the Sophia antigen test and sending off an NP swab. And the correlation has actually been perfect so far. We haven't had that many cases positive. So I think it depends on which population you're screening. I was a little skeptical, but it actually so far has seemed to be quite good.
Yeah, that's great. And so, believe it or not, the time is flying by, and we've probably got about 25 minutes left. So a lot of questions here on treatment, and I want to get to all those, or as many as we can. So we'll now try to answer in 30 seconds and then have follow-ups if we need to, because we got a lot of questions. All right, so finishing up testing, the false positive rates are very low. That's usually not a problem. False negatives, depending antigen, a little bit more than PCR, and a little bit more, less sensitivity with saliva versus nasopharyngeal, although this is a moving field. So let's move on to treatment. A couple things here. One was about we know that most people are now using remdesivir for hospitalized patients. Remdesivir plus dexamethasone is a kind of a staple, right? what about other treatments? There's a question here about tocilizumab. Some people are using anakinra as an IL-1 block. What are your all's current thoughts about that? Again, let's keep the answers short so we can get to more.
I would say at our place, the first thing to acknowledge is that ICU care has come a long way, and there's been a lot of advances just on the way we care in the ICU for these patients. The cerulumab studies failed. The tocilizumab data is, I think, somewhat equivocal, and so our position is to only use these drugs in a trial at this time.
Yep. Kami, what are you guys doing?
Same thing, that we were participated and it failed. So I think that's the best evidence that we have. Some of the other, similar inflammatory things, we're part of trials, and so we're continuing as far as that. But, using TOCI, just for a patient that looks bad, we don't do that anymore.
Right. One of the really cool things going on that I'm sort of peripherally involved is a large adaptive clinical trial that has 5 ongoing arms they just keep rotating. And I'm on the data safety monitoring board for that. And it's been fascinating because they use different statistics. I'm not going to go into it, but it's a really incredibly efficient way to look at several it's mostly immune modulators right now, but there will be some antivirals coming. So I don't think we should really bog down the conversation and all the different possibilities. But are either of you aware of new antivirals, something other than remdesivir that's coming along?
Well, there are a few antivirals that are in clinical trials. And then there are also some protease inhibitors that would have either processing of the viral surface protein or actually processing of the viral proteins. And those are in development. And so it's hard to know how those are going to turn out, but there are definitely trials starting with those types of agents. I don't think any of them are mature enough to really comment on them one way or the other, unless stuff.
Yeah, there's a cytidine nucleoside that I'm aware of, a variant that's in trials. I know at Hopkins and maybe a couple other places. And then there's, as far as one of the questions here asked about existing protease inhibitors, like the HCV protease inhibitors or the HIV protease inhibitors. Have you all heard any data on those?
Well, I mean, there was the data on lopinavir or ritonavir, right, that it didn't work.
It didn't work.
Right, so we had that data. That's the only thing I'm aware of in terms of a clinical trial data.
Right. I don't know of any really great signal from any of the other antiviral protease inhibitors, be it HCV or HIV. So I think, it's interesting when the discussion happened for the plasma, the donated plasma, everyone said, well, what's the harm? And directly, as far as side effects are not likely too much. But some of the harm that we need to take into account is maybe the opportunity cost. If you're going to be giving something to someone in lieu of something else that might work, like remdesivir and dexamethasone, that could be a cost that really is when people talk about cost benefit. That's one of the things that's a little more subtle.
I think that's a real problem because I've been the PI of a number of clinical studies, and I think because it's so confusing and this is a new disease, there is a lot of anxiety about taking anything experimental, or somebody who wants something experimental has a lot of anxiety about taking a placebo. So we have had, probably almost like an 80% turn down rate over the last month for people who are approached for clinical trials because of those, concerns. And then most of those people end up on convalescent plasma, which I agree is unlikely to harm them and has some pretty sound science behind it, but we don't actually know if it works. And so this is what's very, very difficult, is because we have these monoclonal antibodies that should work and also are testing some of the underlying theories about neutralizing antibodies being good that are underpinning all the vaccine trials. And yet, recruitment for those studies has been very difficult. And I think also, for some of these other experimental drugs, I think there's just a lot of concern because of what happened with hydroxychloroquine. So
Yeah.
people are very nervous.
One of the interesting things in this, it's called I Spy 2, that the study that's the adaptive trial, they're actually doing randomization before the consent. I've never seen that before. And the reason is precisely to your point. That allows the person to, when they get the consent, rather than while they're in the ICU or someplace saying, here are the 5 things that you could get randomized to and blah, blah, blah. They just say, okay, you've been randomized to this. Do you want to participate? And it's a lot more straightforward, and the turn down rates are much, much less. So that's a great point. Let's move on to complications in the hospital, or maybe even outpatient. Bacterial pneumonia. What are we seeing about with that on top of the viral pneumonia?
No, very interesting, right? So this was a big concern because of what we saw with the Spanish flu. The cause of death was bacterial pneumonia, secondary bacterial infection. And the data so far, a little bit conflicting. There was one Chinese study that showed a higher number, 50% of the people who died had a bacterial pneumonia. That has not been replicated. And in fact, the more recent studies show rates of 5 to 15%-ish for secondary bacterial infections. I think it's early days, but it's pretty clear that we were over-treating empirically these patients initially and underdiagnosing them. I think that's the other issue, Mike, is that, initially because of fears about PPE and just fears, I think we weren't diagnostically aggressive enough, and we've gotten better about that, but still a lot to learn.
Yeah, Connie, you agree? Is there anything else?
Yeah, I mean, I agree. And I think based on those early data, in the beginning, everybody was on antibiotics. And one of the things is at our place, we do multidisciplinary rounds. So about a month into it, I talked the hospitals into taking off antibiotics as a default as far as the admission order set. And then, getting diagnostic cultures if there was some sort of decompensation consistent with a hospital-acquired pneumonia. And so that's what we're doing now. And so I think Helen's absolutely right. You need to, change with, what's going on, and then also be aggressive about, a lot of these people are intubated a long time. So you have to entertain other diagnoses if their clinical status changes.
Yeah, we've seen a couple of cases as well, and this has been reported of aspergillus.
Mm-hmm.
Somebody's been in the unit for a while. So that's something to keep your eye on as well. Couple of other questions here. Again, staying with treatment. What about thromboembolic prophylaxis? Inpatient, we're doing it routinely, I suspect. But what about outpatient? I'm seeing a lot of folks who are like me, who have an outpatient COVID clinic. They walk in the door, they don't feel great, they're not sick enough to be in the hospital. Are we concerned about PEs and other things, and how often does that happen? And does it warrant some sort of thrombolytic treatment empirically?
No, it's a great question. I'm not aware of any data or recommendations for outpatients.
There's not, but it is a good question. I think that was the point, that it's well conceived, the question, but I don't think anybody's recommending it now. But it's
though we have very close relationships with a lot of the private practice physicians, and I have colleagues who I respect a lot for their clinical acumen, and I have one colleague who puts people on Xarelto, and I have another colleague who always puts people on an aspirin a day. And, it's hard, particularly with the aspirin, to argue that that's wrong, but there's also no data. And so it's hard. It's really, really hard, because clearly, we were concerned about bacterial pneumonias. There weren't so many, but clearly there's a lot of, coagulation difficulties, and some people have, very, profound problems with that. So that we know for sure, but how you identify them, I don't think anyone knows.
Okay. A lot of people sitting in, there's one follow-up on the aspergillus, and the question is about whether it's truly invasive aspergillosis, and is it more colonization? And in general, if you're looking at a BAL and it's growing a mold and it turns out to be aspergillus, for the most part, we consider that in the setting of an abnormal chest X-ray or CT scan, which is the reason you did the bronch in the first place, that we should treat that as if it's invasive aspergillosis. And so I think most of us are doing that. of course, if you did a transbronchial biopsy and saw invasive disease, it's easy. But I think it's a rule of thumb, if you're seeing culture positivity just from a BAL, that's usually enough. What other types of super infections? There's a question about influenza. What about co-infection? We talk about diagnostic challenges, but what about true co-infection? Helen, do you know much about that?
Well, that's what we're all concerned about and gearing up for, right? And so the good news from the Southern Hemisphere is that that does not seem to have been a big thing, but it's something that we all have to keep ourselves prepared for. And I'm sure we're working in our hospitals on having the diagnostic capability to do all the testing that we need to do to find it if it's there. And then we'll have to figure out how to treat it if it really does occur.
So Helen, one thing that I have a question about, so our sort of surge happened at the very end of the flu season, and because of early reports, we did an RVP, and if it was negative, we did a COVID test. But then cases came out with children particularly having multiple co-infections. And then we couldn't really look at it because then we were, our big surge was in the summer where there wasn't much of any of those kinds of things. So what do you think about that? Because obviously kids and respiratory viruses is a little bit different than adults. And, in light of all the surveillance and all the other things that you're doing with school-age children, how are you dealing with that?
Well, it's a great question. I mean, to be honest, that's not part of the surveillance, right? The surveillance is all focused on COVID. And so I think that that's going to be hopefully a focus of investigation this time around, because we saw influenza decline and then influenza-like illness go up, right? And it was COVID. And in the initial phase of admitting patients to the hospital, we did have some who had RSV or, another respiratory virus with COVID, but it was a few. And then because of our supply chain issues, we stopped doing RVPs. We only did COVID tests because we couldn't, we didn't have the supply. So I hope we'll have a better supply chain this fall.
So switching subjects again, and this is maybe a good one to kind of begin to wrap up. If we have a few minutes, there's a couple follow-up questions, what we've already talked about, but a brand new area is vaccines. So there is a lot going on. I'll just preface by saying that it's amazing. All of us have been involved in HIV, who are on this call mostly, and we've been working on an HIV vaccine for over 30 years. And this thing, the sequence was published on January 10th. By January 12th, Fauci and his team at the Vaccine Research Center had a candidate vaccine, which is now the Moderna vaccine. 2 days, and they had a candidate vaccine. And it's the first of something called an mRNA type vaccine, which is something it's never been used ever in clinical trials or in practice. But the idea is to take a portion of the RNA and inject it with a nanoparticle. And remarkably, at least the phase 1-2 are showing some pretty good, mostly antibody responses, but a couple of them actually are showing some cellular immunity. So there's now 5, I think, that are in phase 3 studies. And I'll plug the Sanford guide here real quick. So the COVID page is updated almost daily, at least every other day. And there's a COVID prevention page that has a listing as best that we can divine in terms of what studies are ongoing. Of course, no phase 3 results yet, but just open up for commentary. Helen, I'll let you go first, and Kami, you can add to that. What do you think about vaccines? Are they going to work?
Well, I hope so. We all hope so. And I think the key thing is that we let the process play out how it needs to play out. That means the phase 3 studies complete, be analyzed, and then be vetted publicly by the groups that are designed to do that, right? So it's the CDC ACIP, who's actually meeting today. And then there's also the Vaccine Biologics Advisory Committee of the FDA. And it's really important that the standards are met for safety and effectiveness so that people have faith in the vaccine. The other thing that's really important is that the vaccine is studied in all the people for whom it's needed. So that includes certainly the risk groups for COVID, but also people of all different race and ethnicities. And we haven't talked about healthcare disparities at all, but this is a disease that unfortunately has reproduced the healthcare disparities that we know so well from HIV and other diseases, right? So people of color are overly represented with COVID, having it and doing poorly with it. And so we need to make sure the vaccines are studied in those groups so that we can, with every conviction, believe in their utility.
Yeah, Kami, put
I
in your
completely agree.
crystal ball. What do you think?
You know, I really hope it works. I think the science behind it is really, really exciting. But, you know, there's a lot that could go wrong. And, you know, and I think because of a lot of stuff that's been politicized, I think there's also a lot of people who would be very reluctant to take a vaccine, even if it works. So I think there's a lot of, you know, issues potentially with the vaccine, but yes, I hope it works. And I think as far as the healthcare disparities, I think that's also really, really important. We also have a COVID follow-up clinic where we, you know, call up patients, make sure they're doing all right and things like that. And one of the questions is actually willingness to participate in research and other follow-up things. And there's actually racial and ethnic disparity as far as, you know, minority populations being much less likely to be willing to participate in research. And I hope that isn't a harbinger of those who will be willing to take up the vaccine.
I think you both have hit on a key point, which is even if we see, and I think it's at best 50-50 that the vaccines will work in terms of protection, even with the great preliminary data of immune response. And I'm basing that on all of our experience with HIV vaccines. None of those vaccines that went to phase 3 with HIV, I'll flip it around. Every one of the vaccines that went forward with HIV had outstanding profiles from what we thought was a correlate of protection, and then learned in a miserable way that, yeah, those responses were there, but they didn't protect. And so that's what a lot of us have had experience with. And so, yeah, hopeful, but I wouldn't count on it. It's not maybe going to be going to Greek tragedy or a deus ex machina, right? The saving machine that pulls it out like Greek gods at the end of the play. Hope it happens. But even if it does, I think you both have touched on the issue of trust. And the reason that studies are done the way they're done is not only to assure that the results are right as best we can, but when you know they've been done right, the studies, then that gives a sense of trust. In any perturbation of that approach, any change, or worse, shortcutting, that takes that confidence away that the result is true and that it's had time to mature, not only in terms of efficacy, but safety, that undermines the trust. And we're, you know, what is it? 40% of people normally get a flu vaccine, at most 50. And you still hear people saying, I'm not going to get a flu vaccine because it gives me the flu. Well, people think that getting a COVID vaccine is going to give them COVID. That ain't going to fly, right? So I just, you know, we put that out there. People think there's some sort of crazy conspiracy among scientists or physicians or others who are saying all that we've just said. What can we say to assure the public that if we do see a vaccine that works, that it's real?
I think we say that the process has worked, right? And the fact that you said, Mike, you know, the time from the sequencing to naming the candidate, that was the science, that was the warp speed. But the clinical trials and the development process that has to be done for FDA approval, there have been no shortcuts taken. And we have commitments that there will be no shortcuts taken. And those external vettings that I mentioned by the ACIP and the advisory committee are to verify that fact. And then people like us, leaders in the Infectious Disease Society and other places, that's our job, right? To be truthful, to speak honestly and clearly, to make sure that people know that there were no shortcuts and that what we see is real.
Yeah.
And I think also from the HIV model that, you know, all of us grew up in the HIV era. And, you know, as you know, HIV is a different disease from when it was discovered. And part of the reason that, you know, we don't have a vaccine yet, but the discoveries have been remarkable is because the scientific and medical community worked well with the community. So the people that we were trying to protect, we worked with. And I think it's the same thing for the people who are most affected, is that we need to go out there and address their concerns individually and as a community. And I think that's something that the HIV research community has done very well. And I think that we need to do that because I think people are confused and scared and a little, distrustful. And we need to go to them and help them to navigate those issues.
Yep. So we're at the end of our time, unfortunately. So I'll go in a little bit of reverse order. Kami, I'll let you start with a maybe 1-minute summary of just your overall thoughts on COVID, or the things that, whatever you'd like to say at the end to summarize. And Helen, I'll go to you and I'll wrap up.
So I think for us, it's very, very important for all of us to play our role. So if you're out in the community, you want to take responsibility for yourself and, and your community. And that means wearing masks and try to stay informed. And for all of us who are medical and scientists, work as a team and, listen to each other and try to, make progress in that way. And I think, progress will be made if we can keep those things in mind.
Helen?
Great. So, I guess I'll say that today in some ways is a very sad day, right? Our country topped 200,000 deaths related to COVID-19, a number that none of us ever wanted to see. And, it's something we shouldn't get numb to, we shouldn't forget about. But I choose to take that as motivation for us to look forward and say, we've learned, there's a lot we haven't learned, but we've learned about things that work, right? Washing our hands, physical distancing, covering our face, those things work. And that's what we can all do while we wait for the vaccine, while we wait for better therapeutics. And if we do that, it's going to allow us to keep our kids at school and keep our businesses somewhat functioning during this. And so that's my hope as we cross this day that we didn't ever want to cross.
Well, I don't have a whole lot to add to that except to underscore and to just say that we can all get embroiled in the politics if we let ourselves. And I think we'd be better served looking at things and saying, what are the lessons we've learned so far? What do we wish we had done differently? And to me, I'll pick up on what you guys just said. If we just do the fundamentals well, I'm not going to dwell on how we got to 200,000 deaths, except to mourn that. But let's draw a line right now, today, and we're going to triple down on our efforts to do all the things we know work. Because I think Dr. Redfield said it right, that masks combined with a vaccine are our best hope. And until we get the vaccine, let's really push on these masks. If 98% of us wore a mask when we're out all the time, we can curb this infection by up to 85 or 90% if we did it religiously. And so people don't want to be locked down. People don't want to be inside. We want to get out. But with that comes a little bit of an obligation to do our part. And these things are simple. They're not asking for us to pay money. It's not asking for us to really go too far out of our way. It's just simple. Wearing a mask, keeping distance, avoiding large crowds, and especially avoiding large crowds where people aren't wearing a mask. And we can keep ourselves and our families and our communities safe. Scott, I'm going to turn it back over to you, but I wanted to thank everyone for, especially our panelists, but all the audience who hung with us for this. And I think I was very pleased that the time went by very fast, and hopefully we'll be able to do this again, not only on maybe a COVID topic, but maybe other topics in infectious diseases. And so I'll turn it back over to you, Scott.